Okay, so now I'm going to do a cardiovascular and respiratory assessment on this patient. So the first thing I'm going to do is listen for the patient's heart sounds. So I put on my stethoscope. And the first sound I'm going to listen to is the aortic valve, and that is located at the second intercostal space right of the sternum border. I'm going to listen, just for 4 or 5 beats. I want to assess the rate, the rhythm. I'd want to listen for that lub-dub sound, which is also your S1, S2. You'd also want to make sure that the heart rate was regular, that it wasn't irregular. Then I'm going to listen for the pulmonic valve, which is located left of the sternal border in the second intercostal space. I'm going to listen for the same types of things: rate, rhythm, regularity, S1 and S2. Then I'm going to listen for the tricuspid valve, which is located at the fifth intercostal space right of the sternal border. And then the last one I'm going to listen to is the mitral valve, which is located also at the fifth intercostal space, but it is left of the midclavicular line, which is this line right about here. And this is also known as your apical pulse. This is where you can assess the patient's PMI. A lot of times medications will call for you to assess an apical pulse for 60 seconds. So this is where you would do that. So next I'm going to listen to the patient's lung sounds. And you can just do this by moving. You want to compare each side each time you listen. So I'm going to start up here. And you just want to listen to a couple breaths in and out. Then I will move to the other side in the same spot. And then just move down. And then across to the same spot again. And then move down. Across. And then I'd also listen to the lateral portion of the lung. So that's on each side of the rib cage here. I'd also have the patient turn over at this time or sit up if they could, so that I could listen to their back, so that we can listen to all fields of the lungs. Just do this in the same manner. So you'd want to make sure that you do not place your stethoscope over the scapula or the spine, because those are bones and you're not going to be able to hear anything. You're also going to want to go ahead and take a look at the patient's skin back here. This is another part of the skin assessment. You want to assess for any redness. Are they developing any sort of pressure ulcer? You'd want to look for any sort of lesions, bruising, tears back here. Thank you, Ms. Gray. You can lay back down. So when I'm listening for lung sounds, I want to see if they're clear, or if I hear any sort of adventitious sounds, such as crackles, bronchi, wheezing. Those are abnormal sounds. I'd also want to ask the patient about their cough. Have you been coughing at all lately, Miss Gray? And she tells me no. But if she had, I would want to ask her if it had been a productive cough, and if it had been, what is the color of the sputum? What is the consistency? How much is she coughing up? Is she having any difficulty with that? So next, I would want to go ahead and assess the patient's pulses. So the first ones I'm going to do are the radial pulses, which are right here. And you want to try to feel both of them at the same time if you can. That way you can compare if they feel equal or not. But sometimes you might have difficulty, so if you need to feel one at a time and then compare, that's fine. So I'm going to assess the radial pulses, the brachial pulse, And we aren't gonna have you all feel the femoral pulse, but if you were, you could assess their femoral pulse right here. Then I would assess the popliteal pulse, which is behind the knee, and it's sometimes difficult to find. Then I would assess the posterior tibial pulse, and then the dorsalis pedis. And a normal pulse is usually considered 2+ to 3+. A 1+ is considered a weak, thready pulse. A lot of times people who are dehydrated have this, or other issues. And then a 4+ is considered a bounding or an incredibly strong pulse. And that is it for the cardiovascular respiratory assessment.